we coordinate the AMR Multi-Partner Trust Fund on AMR, the MPTF on AMR, which is a core, very core project what we are doing. We coordinate the monitoring of quadripartite work plan, implementation and mapping gaps and opportunities, and then of course the coordination and partnership of the core organizations and widening it out to other stakeholders. There is a strategic framework that we have established on the collaboration on antimicrobial resistance of the situations. And this is a framework on our collective work. It's about work that we do together, where we think that we can actually advance by working together. We, of course, the four organizations have also our own mandates and tackling AMR also individually, but this is really about the how we work together. We have a theory of change, and I'm not expecting you to read it. It's just to say that the goal is actually to preserve the antimicrobial efficacy, but also to have equitable access to antimicrobials for the responsible and prudent use in humans, animals, plants, and contributing to the SDGs. And we want, the impact is that countries have the capacity to design and sustainably implement evidence from the One Health response to AMR. So this is where we want to go with it. If you look at the table here at the bottom, or at the graph there, at the bottom you see that there we have the global action plan. It links to the global action plan and builds on the global action plan. And then there are country-specific issues that we really try to deal with, one of them through the MPTF. And then, of course, we have also regional and global activities. So to try to scale up the action against it. I mentioned the multi-partner trust fund, which is really one of the core issues. It is currently not a big multi-partner trust fund, but still it is already, it's young, it's already coming with some results. There are 4 global programs, and then there are now 12 coming country programs, around 26 million. Current donors, as you see, is European-based. It's Sweden, Netherlands, Germany, and the UK. And as I said, 4 global projects. TISSA, because Arno will talk about TISSA in general. There is a specific project on TISSA. We have a project on monitoring and evaluation, on legal frameworks, and on the environment. And then we have 10 country programs, countries that are already working on their projects, and 4 countries are coming in. So you see that we are actually expanding quite a lot, and some of the countries have already been working for over a year. Another thing that is the global governance structures. Global Leaders Group has been established and is already, as you can see, if you look at their website, you can see that they have already issued a lot of political statements, and they are actually driving the AMR agenda quite on very high level, and you can actually see that there already is an effect of this work, because the AMR is even more now on the agenda than it has been before. So that is really, the Global Leaders Group is really working very, very effectively on promoting AMR response. Led by the 2 excellencies, Leah Amor Motley from Barbados, and Excellency Sheikh Ali Hasina, Prime Minister of Bangladesh. Another of the global governance structures that I want to mention is the AMR Partnerships platform. This is a huge platform that we expect people or stakeholders from all around, from all sectors, private, academia, all sectors, to join forces and to discuss and to come with action against it. And I will not go into details on it. I'm already with my 10 minutes, but we are drafting the terms of reference. They are just about to be finished, and we expect to have the launching event soon, at least this year, and hopefully the plenary session, the first plenary session at the, let's say, at the end of the year. There is one thing more I want to mention, that's the high-level ministerial conference that will be held in Muscat, Oman, from the 24th to 25th of November this year. This is the third one. The first one was in 2014, the second one in 2019, and that actually led to the launch of the AMR and Antimicrobial Resistance with a 5 million initial funding by the government of the Netherlands, the conference was co-chaired by Indonesia. Potential outcomes for this are now being discussed. And then just at the end, I just want to say that, I mean, the importance of, I just want to explain or highlight the importance of collaboration. And a collaboration between all sectors and all stakeholders. If we think of the drivers of the antimicrobial resistance, I'm not going to read this up, I'm just going to remind you that the drivers of antimicrobial resistance are so diverse that we really need to work together. We cannot compete, we should work together. We have scarce resources and we should really use those scarce resources where they best fit. So with that, I will say thank you very much for your attention.
Okay, thank you very much, Dr. Valsson, for your excellent presentation. So his presentation highlights by the key information that we covered to try to cover the one approach that is human, humans, animals, and also environment. I think that from this experience, we need to think about this one in order for us to translate the success from global level into national level later. So now I will have all four speakers to present their presentations. After that, if you have time at the end, so we would like to welcome your questions or any comments that you may have for any of the four speakers. So I will move to the second speakers. Second speaker is Dr.Catrin Moore. Dr.Catrin Moore is from St. John's University of London. She is a microbiologist and team leader in the global research on AMR on the ground. On her presentation, she will share her experiences to joining in his grant project. So may I invite Dr. Catrin to present your presentation. Thank you very much.
Okay, thank you very much. Saudi Care, thank you very much for inviting me, for the organisers for inviting me today to present my work on the global burden of antimicrobial resistance and to start to make the next step and introduce a new project to you today. And the work on the global burden of antimicrobial resistance was a partnership between the Institute of Health Metrics and Evaluation and the University of Oxford, where I was based previously, leading a group working on this important project. So I will just briefly give a little bit of background or start to think about some of the questions we as researchers have been asking over the last 2 years. We've been thinking about what antimicrobial resistances, what the drivers are to increase that antimicrobial resistance. But also the question that we've started to answer is, how many people die because of antibiotic resistance, and where is the highest burden of those deaths? One question that I wonder about is whether antibiotic use alone drives resistance. We know that it doesn't, but what else are the drivers, and how can we reduce antibiotic resistance because of those drivers? I think Human behaviour is a huge driver of resistance. I think over the next few years we will start making inroads in reducing resistance and antibiotic use through human behaviour. And we will start to see more vaccines being introduced, I think, to combat bacterial infections to reduce AMR. And thank you to Olafur for an excellent talk about the political will and what's changed politically. So I won't talk too much about this slide, but this really does highlight to me how political will has changed over the last 10 years. Starting with the UK government commissioning the OIE report, which then led to the Global Action Plan, GLASS, National Action Plans, and now we have the G7 health ministers communicate who brought antimicrobial resistance in with pandemic infections and climate change to say these are the major problems that we have at the moment that we need to tackle. It's really great to see two new indicators within the Sustainable Development Goals on MRSA and E. coli that are resistant to third-generation cephalosporins. This means that we have indicators that we can look at in bloodstream infections. We can see how these change over time, and it gives us a measure. It's also good to see that antimicrobial resistance and use is going to be discussed at a UN high-level meeting in 2024. So we really are on the global agenda, and we need to make the most of this, I think. One thing to say is that much of our work has been looking at human infections, but as we go forward, this is really expanding to One Health. So we're really looking at the whole pandemic. The work that I will talk about today is just looking at human health. But going forward, I'm sure we will expand that. So where were we? When we started the project, the GRAM project, so Global Research on Antimicrobial Resistance, where we were was using the O'Neill estimates. And we all know the numbers for the O'Neill estimates. We all know that death attributable to antimicrobial resistance was going to be higher in Africa and in Asia, based upon available data at the time. So within the GRAM project, we really were tasked to collect as much information as we could in as many places as we could to really understand the burden in much greater detail. How did we do this? Well, we started off with the Global Burden of Disease database, and as we collected more data from others, this fed into that database to really understand the burden of diseases. And then we looked at the proportion of deaths that were due to sepsis within that database. And why sepsis? Because if somebody dies due to antibiotic resistance, they would go through the pathway of sepsis. So it seemed a reasonable start to say that if anyone dies because of AMR, they will have sepsis, and we will pick them up that way, so that we will see them in the database. And then looking at within sepsis, what is the burden of the different infectious syndromes, broken down to lower respiratory infection, bloodstream infections, and other infections. And then we broke that down to the burden due to each pathogen. So we had infectious syndrome, and we had each pathogen separately. And then looking at the burden of the pathogen and specific drug resistance. For example, if you have a patient who has Streptococcus pneumoniae that's resistant to penicillin, that's coming from a patient who has lower respiratory infection, who has sepsis, that would be one of the areas that we will be looking at. We'll be looking at this for many different infectious syndromes, many pathogens, and many resistances. And in the end, we looked at 23 different pathogens and 88 drug combinations within our estimates. And instead of just doing the one method, looking at resistance compared to sensitive infections, we looked at the resistance and sensitive, but also resistance versus no infection. So we had two different counterfactual examinations or modelling methods in our models. And what did we find? We found that more people were dying than we thought. In 2019 than we thought in 2016 in the OIE report. So we had nearly 1.3 million deaths that were attributable, so that's resistance being replaced by sensitive infections, and nearly 5 million were associated with AMR, so that's resistance being replaced by no infection. And these give us a lower UNEP measure with the surrounding uncertainty because of the modelling methodology. This really means that AMR is a leading global health issue, and it really shows that people living in low and medium income countries are more likely to die because of AMR than they are in high income countries. And just looking further, when we looked at the global burden of disease regions, you can see here that here we have the attributable to resistance deaths down the bottom, the lower levels, and those associated with resistance, the higher levels. And what you see in all of these is that more people are dying in Africa, in sub-Saharan Africa, due to AMR than elsewhere. And if you look at Southeast Asia, it really is quite low in the list of countries. So the burden of mortality in Southeast Asia is much lower. In Western Sub-Saharan Africa, we see that 27 people per 100,000 die due to antimicrobial resistance. And when we compare that to Australasia, where 6.5 million per 100 million people die, that's much, much higher, and we should really be concerned. And then when we look at the different pathogens that people are dying with, we can see that those differ across the regional countries, regions in the world. And in Southeast Asia, we see that more people die due to Acinetobacter baumannii and E. coli, so those are the top two pathogens, compared to somewhere like Sub-Saharan Africa, where Klebsiella pneumoniae followed by Streptococcus pneumoniae are the biggest killers in that region. So what this means is it prioritises the different pathogens that we need to look at in the different countries. And what we see overall is that 3 infectious syndromes really do cause the highest number of deaths. That 80% of people die because of lower respiratory infections, bloodstream infections, and intra-abdominal infections. So as well as the pathogens, that also prioritise infectious syndromes we should be looking at and treating in our clinics and outpatients as well. So the main outcomes are that AMR is the leading cause of death globally, but it's higher than HIV/AIDS and malaria, which may surprise some. That we see the highest burden of death in sub-Saharan Africa, but also the GBD work really supports some suggestions made by the OIE report that we could have some simple improvements in WASH and infection prevention and control, which could decrease the burden of AMR considerably. But also that with the 7 bacteria that cause the most infections, only 2 of them currently have vaccines. So if we have vaccines for the other 5 bacteria, a lot of deaths could be avoided. So these may be areas that we want to concentrate on in specific countries where the burden is really high. And I think also the really important thing here is this provides some evidence for us to move forward and to really think about implementing different programs to reduce the burden of AMR. And with that, I want to move on. So we have some information about resistance and the burden of resistance. But what about antibiotics? We know that overuse and misuse of antibiotics drives antimicrobial resistance. And we know some of the reasons that clinicians use antibiotics and pharmacists use antibiotics, because they want to make sure that their patients are well, that their patients don't get sick and get sicker, that they get better from the infection. But what I think we need are really good policy guidelines surrounding antimicrobials. And within that, I think we really need the policy goals to really think about the AWARE system as was introduced by the WHO in the Essential Medicines List, first in 2017, which is being updated this year and will be published in November this year, which splits antibiotic groups into access, watch and reserve antibiotics, where physicians and dispensers should really concentrate on using access group antibiotics as their first and second choice, and that we should have more than 60% of our total antibiotic use in the country coming from that access group antibiotics. I would say maybe that needs to be increased, more than 60%, but I think part of our work in the project that we're doing is to understand that and see what that might look like. And what we do know over the last few years is that low and middle income countries now are starting to use more watch antibiotics because there's more resistance in country and because physicians want to make their patients better. We also know that there is a growing problem of inappropriate use of antibiotics, particularly when a patient has a lower respiratory infection and it's treated, but it's a viral infection but treated with antibiotics. We still see a lot of that in many, many countries. We really need some policies to reduce the use of antibiotics in those areas. So our question in our new project is whether we can have policy goals for all antibiotic consumption, thinking particularly in primary healthcare setting, where over 90% of antibiotics are actually dispensed. And this would be based upon the AWARE system, really pushing to have the first group of antibiotics used rather than the reserve antibiotics. And so some of the work that we're looking at is outlined in our new project called the ADILA project, which is AMR data to inform local action. And this is a project based in St George's, where I am now based with Mike Charland and a group of researchers both in Thailand, in Laos, in Vietnam, Kenya and the UK, to really understand what the local data looks like and to change policy based on the AWARE categorisation. So the background is that we have the global prevalence of resistance. We have the global WHO EMR list, which says you should use certain antibiotics for certain infectious syndromes. How do those two meet up in countries and in local hospitals? And how do physicians know how to treat those infections? I think we need to start modelling data to understand which antibiotics should be used in which countries. So within that, our goal is to optimally use antibiotics, to support countries improve the quality of that antibiotic use. And within this, we have 4 different areas where we're looking at hospital data, so retrospective data which has been collected, where we have the clinical information, microbiology data, outcome data, but also antibiotic use to really understand the treatment and whether that treatment for a patient is concordant or discordant. What we plan to do in the hospital is to model a hypothetical clinical trial based on the data that we're collecting. And then moving across to primary healthcare data, there is very little data in primary healthcare. Some of the data that's available is in outpatients, very, very, very little, if at all, any in the community. And what we want to do in the primary healthcare system is to look at observers in expected prescribing. So what do people prescribe and what should they prescribe? To run some surveys to understand what people are prescribing, but also to start looking at some quality indicators that we could maybe bring in primary healthcare system. And then looking at the clinical impact, we're looking to determine antibiotic targets through the clinical burden, so understanding that clinical burden and what targets might fit with the burden. And then really outline data that's needed for prospective collection for clinical trials going forward. And something that's really important here is the implementation. We will work with countries to really build the capacity. We're going to share all of our tools openly online and with countries, and the codes that we use for those tools, so that researchers from countries can use their own data to really make a change to policies in their countries and to reduce antibiotic use and misuse in their countries, which is really important, that we're actually implementing things to make a change. And with that, I just want to say thank you very much to the Crown team, also to the Agility here in St George's, and to our funders, the Department of Health, the Wellcome Trust and Bill and Melinda Gates Foundation. Thank you.
Thank you very much, Dr.Catrin Moore. I think that you have presented something very scary. So you can see the global burdens number of deaths. 1.7 million directly associated with the AMR. 4.95 million. We still have a big burden. She has introduced new projects of AMR. I think this is one of the good things that we need to learn to see how can we have data at a global level to be translated into local action. So I think if you have your question in mind, keep for a moment. At the end of the sessions of 4 of them, you have a chance to directly ask the question to the speaker. Now we will move to the third speaker. The third speaker is Dr.Arno Müller, and he is a technical officer within the Antimicrobial Resistance Division and WHO headquarters, and is the leading team responsible for surveillance of the use of antimicrobials. Today he will talk about the Tripartite Integrated System for surveillance on AMR and AMU, antimicrobial use, and TISSA, which is a platform to share data on AMR and AMU across human, animals, and agricultural sectors. So please join me and warmly welcome Dr. Arno Müller.
Good afternoon. Can you confirm that you can hear me on the screen?
Yes, we confirm that we can hear you clearly. Please.
Thank you. First, thank you for inviting me to this meeting to present TISSA on behalf of the Quadripartite organizations. What is TISSA? TISSA means Tripartite Integrated System for Surveillance of Antimicrobial Resistance and Antimicrobial Use. It is an initiative initially from FAO, WA, formerly OIE, and WHO. You all know to some extent the politics of AMR. You know that AMR is a complex with many factors impacting development and share of AMR. AMR has no border in terms of countries, but also in terms of sectors between humans, animals, and agriculture. Then we have to take a one-health approach if we want to tackle AMR. And in order data from relevant sectors to act within to our integrated surveillance systems that generate evidence for action at country level and also at global level. And as was mentioned previously by Dr.Olafur, we have surveillance structures at global level with the Quadripartite Coordination for Awareness. That is the umbrella for this one. Well, we need data on AMR use because use is one of the main factors that drive the development of AMR, and it's important to have this data in the different relevant sectors, both data that will influence each other and will influence resistance in other sectors. Basically, at the moment, we have a lot of information that from regional initiative and mainly from the European region. When the Global Action Plan was adopted in 2015, it was adopted by the organization, and surveillance was a key component of the Global Action Plan. And what is important is that each organization decided to support countries to collect data on the global level according to their respective mandates. And then we had internal discussion for a while, and then in 2017 we had a discussion and we said, okay, we should set up a common repository of data on antimicrobial resistance and antimicrobial use across human, animal, and agricultural sectors. How we were starting to support countries to collect data according to our mandate in all these fields. Then it took a bit of time, and between 2018 and 2020 it was important because we got support from the senior management of the three organizations, and at the end we had the tripartite agreements to move on for TISSA. Then in 2021 we had the opportunity to start development of the TISSA platform thanks to the LBTA that mentioned. With this fund we were able to move on the project. And the system is still in development and we aim to launch the TISSA platform by the end of this year. What are the objectives of TISSA? TISSA is to develop and maintain a global platform to make available and share data on antimicrobial resistance and use across human, animal, and agricultural sectors. Again, mentioning that it's using data that are collected by each organization's respective global surveillance systems. I'll come back to that later. And with this repository, the idea is that we should be able to foster integrated analysis of data across sectors and foster integrated surveillance at country level. As I said, we need data for action, and there is two main areas where TISSA can contribute. The first is to understand the AMR ecology across sectors. Is to understand transmission of AMR across sectors, what are the AMR epidemiology, what are the chain of transmissions within a sector and across sectors. Is to understand the impact of use of antimicrobial across sectors in the development of AMR, obesity, selection pressure. What we do in animals, what impact on AMR in animals, and then subsequently, for example, what could be the AMR development in humans based on that fact. Or the other way around. Is to understand, to help understanding the development of AMR in animal health. Just Catrin mentioned, for example, what can be done in humans, but we could do similar animal health, for example, and by identifying problematic pathogens for public health, for animal health, and agri-food industry. And then this is really important information. And with that information, decision makers can decide what to do to control AMR in specific sectors, to limit the spread of AMR to other sectors, and to implement health management policies. Another area that is also very important for TISSA is pharmaceutical market and national use. With TISSA data, we can understand the market dynamics and use behavior across sectors. For example, what would be the changes in market regulation or medicines policy in one sector impact other sectors? For example, if we buy medicines in one sector, what will happen to the other sectors? Would medicine from other sectors be used for the sector where the antibiotics, for example, have impact? All these things, that will be important to know. And again, with this data, we can help decision makers to take right decisions in terms of regulating medicines, including the enforcement of this regulation, in terms of procurement and supply of medicines, to improve the supply chain and the access, availability and affordability of medicines for different actors. And finally, decision makers to improve policies and national development. Now back to TISSA.
Thank you ก็ดิ่งขึ้น4ขั้นแต่ตอนแรกก็ได้นะแต่พอขั้นขึ้น4ขั้นนั่นแหละเนาะจะได้จบๆไปส่วนของไฟล์ของภูเก็ตไม่ได้ไม่มีตรงนี้ละ
พี่ก็เดี๋ยวอัปเดตลงมาเลยนะเดี๋ยวแยกโฟลเดอร์ไว้ไงจะได้นี่
มันก็เปลี่ยนนะเหนื่อยละแย่คุยลูกค้าไปแล้วก็อย่างที่นี่แหละ
ต้องมีอัปเดตอีก
อัปเดตเรื่อยๆตลอดเวลา
ยันก่อนขึ้น
That is collecting data on antimicrobial resistance initially as part of the mandate collecting antibiotic use in agriculture in the future.
ต่อไปด้วยเหรอวันนี้
What will be the TISSA functionalities? Basically, TISSA, as I said, is a repository of information, and there will be two types of information in TISSA. The first one will be the database on AMR and AMU, collected by the organization, and the data will be reports on AMR and Initially, data will be separated by sectors. On the long term, we will also be close reports between sectors. And also, we need to provide additional information on wellness surveillance when we think it's relevant to share to the public. What are the requirements in terms of data to make a TISSA? As I said, data comes from 3 different systems, and we have 4 main protocols. But what is important is that these systems produce comparable data, for example, between AMR in animals and humans, and used in animals and humans. That means that the data should be collected according to protocol that are online. They use asymmetrics to report data, and the data are collected in the same settings at the same time, which for TISSA is basically monitoring on a annual basis. And it's important that we have this standardization put in place when we collect the data to ensure that we can put all the data together. And standardization is important, and there is 2 ways to have standardization through protocols. The first one is to have different protocols, and basically this is what we have currently in TISSA. Each of the organizations has developed their specific protocols, because these protocols will respond to specific needs in each sector. For example, the WHO is developing protocols to answer questions in public health, in human health. FAO is developing a surveillance system that will answer questions from farmer and animal health professionals. The same as for OIE. Data in this case can be collected in different settings, different pace. What is important is that we have bridges and alignments between the different protocols. For example, the data collected by the WHO and our antibiotic use are comparable. The other option is to go with integrated protocols. In that case, we have one protocol that is designed from scratch as a 1S protocol, and data are collected at the same time with the same settings, but often you just focus on a subset of common data information through these protocols. Then it's integrated but narrow in terms of scope. And one of the best examples is the WHO tricycle ESBL coding protocol. Then, just to remind you that TISSA will the first approach with separate protocols for producing comparable data. In terms of metrics, we have common metrics, we use stones, and we have the same antibiotic class when we talk about antibiotic use. On AMR, we have also the same parametrics, proportion of resistant isolates and the total isolate, and we have definition of resistance when specific to one else without taking into account on these blood types. And we also have the same definition for specimen. And in terms of development, as I said, we will have the first step, which is the platform that will be launched in November, where we will have a common repository of data that have been created according to the protocol that have been aligned. We will use the same metrics and indicators, but as I said, data will be initially reported separately. We will have reports in numerous reports in numerous and AMR and we separated. But we will improve the data we have, and we expect in the future to be able to do cross-reporting, where we can analyze AMR and AMR data together. But we need comparable data, we need the same country, same year, which we don't have yet, because we are starting. And in the future, analyze them together and across sectors. But that will need some statistical requirements and models that we need to develop. What is important is that the work that is done at global level can be also implemented and transposed at national level. We are using the global protocol that countries are using to report to the different organizations, which means that countries already have a protocol that produce comparable data if they follow the global protocols. The TISSA metrics standardization can be easily transposed to national surveillance systems. And we think that the work that is done through TISSA on cross-reporting personalized value guidance for countries to repeat reporting analysis at national level. What we do at global level, we should be able to do it at national level. And the work of TISSA is complemented by other guidance. For example, we have the AGISA guidance on integrated surveillance of antimicrobial resistance that can be used also for countries. It is important when you want to transpose one else system like TISSA, that the system is adapted to your context. And in conclusions, I think that TISSA is also a repository of AMR and data across sectors, managed by the Quadripartite organizations. Initially it's still Tripartite, but we are looking at integrated UNEP in TISSA. Importantly, data are collected from Tripartite organizations respective to global surveillance system and not from a specific dedicated system. TISSA should foster understanding of AMR across sectors and foster one surveillance in countries. And finally, we aim to launch the platform at the end of 2022. With that, I thank you.
Thank you very much for your informative presentation. So you can see that from the early phase of the AMR strategy, information is the key to success. And you can see that the platform that's to be launched this year, TISSA, can help us But if you observe about the presentation before the last one, no matter what you go from TISSA platform, you have to think about the local context. How the information you receive can be fit or adapted to fit the local context. And I think that at least TISSA will give you a platform. So in the future, we hope that this key information can help us at the national level to tackle for AMR. So thank you very much. Now we will move on to the last speakers. The last speaker is Professor Anthony D. So he is a professor of the practice and founding the lecturer of the Innovation and Design Enabling Access Initiative in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And he also served as director of the Strategy Policy Program or REACT, Action on Antibiotics Resistance, and head of the Secretariat for the Antibiotics Resistance Coalition. So today he will be with us. So for his presentation, this is already recorded beforehand. That's why he will give you a pre-recorded video. And after this, we come to join you live on the online. So I would like to welcome for the video from Professor Anthony D. Please.
Thank you for the opportunity to share a few reflections on how we might draw lessons and synergy between COVID-19 and antimicrobial resistance. I've opted to deliver these remarks by recorded presentation, just in case internet connectivity, or given that we're here in the United States, neural connectivity might be limited. Meeting these pandemic challenges in our healthcare delivery system opens the door for us to consider lasting changes, ones that also offer co-benefits for tackling AMR. Could we build a more resilient healthcare system that traces and quants zoonotic disease transmission, that supports integrated disease surveillance, that ensures effective infection prevention control from PPE to respiratory support and oxygen therapy, and that builds surge capacity for delivering health commodities from antimicrobials to diagnostics and vaccines. While tackling AMR and COVID-19 may require distinct strategies, can we find common cause, for example, in building a global wastewater surveillance system that might spot the next outbreak before it becomes a pandemic? This has been proposed for drug-resistant infections several years ago, and is how we are now using the infrastructure of the Global Polio Laboratory Network to track COVID-19. But it is in the surge capacity to develop and deliver health commodities where we might draw lessons and synergy with COVID-19 through an end-to-end approach. WHO's recently released 2021 update to the antibacterials under development shows a continued pattern of a pipeline with very few truly innovative compounds targeting priority pathogens, particularly multi-drug resistant gram-negative bacteria. And the engine behind much of the preclinical pipeline remains small firms, most with fewer than 50 employees. Since WHO's first analysis of this pipeline in July 2017, 12 new antibiotics have come to market, receiving either US FDA or EMA approval. By contrast, the pace of COVID-19 vaccine development has been breathtaking, with 11 receiving WHO emergency use listing to date. The question is whether we can apply approaches taken to speed R&D for COVID-19 vaccines and therapeutics to ensuring sustainable access for antibiotics. To be sure, there are important differences. The need for COVID-19 vaccines is near universal, while the demand for novel antibiotics for drug-resistant infections a limited market. And vaccine R&D, even for COVID-19, has proceeded at a much different pace than therapeutics or antimicrobials to treat COVID-19. Still, as the Lancet grants to observe, there are only vaccines available for one of the 6 leading bacterial disease pathogens, strep pneumonia. To tackle this clinical equipoise between access and excess, the WHO has put forward the aware classification of antibiotics on the essential drugs list into access, watch, and reserve categories. But how does this translate into economics of ensuring sustainable access to antibiotics in the marketplace? Along those lines, the policy concept of delinkage has received much attention. Much of the global health community views delinkage in the way the WHO's consultative expert working group defined it a few years back. Delinking as a means of divorcing the funding for R&D from profit pricing. When the consultative expert working group described the idea, they envisioned that generic competition would bring pricing close to marginal cost. Later, however, delinkage has been discussed in circles involving innovation and antibiotics. Here, delinkage seeks to divorce return on investment from the sales volume, or in other words, price times quantity. And in tackling antibiotic resistance, quantity matters. For antibiotics, the greater use of antibacterial drugs results in greater resistance. But how do we achieve delinkage? It is quite challenging to accomplish because reimbursement mechanisms cannot easily delink the returns to the drug company from volume-based sales. Yet drug companies are most keen on governments hiking the return on investment by paying more for the outputs part through market entry rewards, subscription programs, higher drug prices, and transferable exclusivity extensions. We'll focus here, however, on several policy levers over which the public sector can apply to support more of an end-to-end approach, from how we finance innovation to full procurement and public sector manufacturing. One lesson from COVID-19 is that we must consider more strategically how we deploy push incentives that pay for inputs of R&D and pull incentives that pay for the outputs of R&D. With the billions of dollars that governments like the United States put into financing COVID-19 vaccines, diagnostics, and therapeutics, how do we ensure fair returns on this public financing? In pursuing an answer to these questions, we have recently seen efforts to invest in innovation platforms, like the Regional Technology Transfer Labs for mRNA vaccine development. Public investment in the mRNA vaccine platforms might allow for this to be repurposed to different endemic disease targets, from influenza and HIV to respiratory syncytial virus and maybe even malaria. A boon to this area may be the emergence of the thermostable mRNA vaccine platforms, as the cold chain requirements have constrained their use in resource-limited settings. One such promising development might come from a product-driven partnership with Access to Advanced Health Institute, which is keenly interested in transferring the technology for local production to low and middle-income countries. Within the past couple weeks, we've also learned of a promising licensing arrangement between the Japanese pharmaceutical firm Shionogi, the RFP and Product Development Partnership, and CHI, the Clinton Health Access Initiative. In markets across 135 countries, RFP will have a non-exclusive license to issue sub-licenses for local production of Spidolol. Shionogi will provide both technology transfer and product registration right of control to national regulatory bodies and the WHO qualifications program. Now, we're only beginning to appreciate the implementation details of this arrangement. Cost of recoupment on net sales will be 0% on low and low-middle-income countries, 5% for upper middle-income countries, and 9% for high-income countries covered under this arrangement. However, while India and Brazil are covered under this licensing arrangement, China and Thailand are not. But there may be potential down the road to emulate and expand such an approach. A key policy lever for ensuring more effective, affordable, and sustainable supply of antibiotics is for greater public or non-profit engagement in manufacturing these products. With shortages, price hikes follow, and public sector supported manufacturing can help ensure security of supply. It can also align supply with appropriate demand in ways consistent with public health needs. And finally, perhaps it might also yield insight into pharmaceutical pricing with clearer transparency of inputs and outputs of the manufacturing process. Several different approaches might be taken. First, the public sector in some countries has also played a role in supply of drugs and vaccines, from the Walter Cruz Foundation and Hopkins in Brazil to state-owned production in China. Here, the gulf between what innovation is incentivized by a paying market and what innovation is a public health priority can be bridged. For example, the Brazilian-owned pharmaceutical company Hopkins of Cruz developed and registered with DNDi a novel fixed-dose combination for malaria, ASMQ, comprised of artesunate and methylprednisolone, and subsequently the technology has been transferred to the Indian generic company TISSA. Secondly, the private sector might receive push or pull financing to build capacity or speed scale of manufacturing. We have seen this with the rollout of innovations like COVID-19 vaccines, where public sector supported manufacturing ensures security of supply of an innovative product. In retrospect, we clearly could have done more to place access conditions on what we publicly financed. A third approach has emerged more recently, where the healthcare delivery system takes over producing pharmaceuticals. In the United States, CivicRx has emerged as a non-profit generic drug company, led by Intermountain Healthcare, about 40 healthcare organizations, and several foundations. they initially announced that they would prioritize producing generic drugs that met several criteria. The drugs would be on the WHO Central Drug List, saw a price increase of 50% or more over the past 2 years, and/or had faced shortages. Members are allotted a fair share of Civic manufactured drugs, and this system ensures that its long-term volume commitments will allow a lock-in the prices that are both reasonable and transparent. While it may acquire eventually its own manufacturing facilities, it has begun striking arrangements first by contracting with generic suppliers. And at the front of the line, Civic-Rx's first 2 generic drugs for production were vancomycin and daptomycin, 2 key antibiotics under a partnership arrangement with Xelia Pharmaceuticals. What's particularly exciting about this business model in bringing new antibiotics to market is that it has the potential to align the interests of providers and patients in the healthcare delivery system with the interests of the drug manufacturer, which is now vertically integrated into its operations. We'll have to see how things play out, but this has the potential to become a truly driven model. Full procurement represents another key leverage, one that could be used more strategically in market-shaping interventions. Arguably, in responding to COVID-19, perhaps we might have leaned more heavily on this theme, and we can learn upon and perhaps build upon the experiences of the global facility. It has become a one-stop shop for TB medicines, diagnostics, and supplies. Through its efforts to full procurement of these commodities, it has helped to ensure stable, forecasted demand for suppliers, a prerequisite for keeping suppliers in the relatively small markets of treatments in multi-drug infections, and at the same time to negotiate concessionary prices from those manufacturers. It has brought useful experience and expertise in fielding procurement tenders at a time when countries are beginning to pick up more of the responsibility for procuring these products from the global market. Importantly, it has also created a strategic rotating stockpile that allows it to smooth out the disruptions of spot shortages of some TB products by ensuring those who need the product now get it first and others later. And in providing technical assistance to country programs, it can help support scale-up of the use of antimicrobials in resource-limited settings. While much more could be done for addressing TB, the Global Drug Facility is playing a key part in procuring adapalene, delaminated, child-friendly formulations for treating drug-sensitive TB, and also expert system cartridges for diagnosis of drug-resistant TB. And we will need some institutional infrastructure beyond TB to ensure an end-to-end approach. Paving the way for an alternative business model will take work. A year ago, Tripartite, along with the WHO, UNICEF, and the Community Health Access Initiative, announced the launch of the Secure Initiative. This is more of an idea or concept that they were going to put together a portfolio focused on antibiotics, both normal and existing, that required more of an end-to-end approach to ensure sustainable access. This would include tackling the supply chain interruptions and shortages, with clinical studies to expand indications or geographies, and integrating these efforts with existing procurement, supply chain, and finance structures. A year later, a new business model for the Secure Initiative is emerging, with aspirations of working across the pharmaceutical value chain from full procurement to stewardship. The Secure Initiative in finance could become a vehicle under which several of the approaches we've discussed might be carried out. It will likely then take other partners, including governments and civil society, if this is going to be an idea on the drawing board, a vehicle for advancing the new business model, drugs, diagnostics, and vaccines tackling AMR. So why, with this increased policymaker awareness of emerging infectious diseases like COVID-19, have we spent trillions of dollars responding to the pandemic? But the UN Multi-Partner Trust Fund on AMR, after over 3 years of operation, has only raised just under $20 million. Honestly, I cannot think of a good reason. Even before the pandemic, the World Bank projected that if AMR goes unchecked, up to 24 million more people could be forced into extreme poverty by 2030. It looks like COVID-19 might have beaten AMR to the punch there. But under the high AMR impact scenario, this could amount to 3.8% loss of annual GDP by 2050, with annual shortfall $2.4 trillion by 2030. The bank has concluded that, quote, putting resources into AMR containment now is one of the highest yield investments countries can make, unquote. By investing just $9 billion a year in low and middle income countries, we could avert trillions of dollars of potential economic losses, Significant returns on this investment were accrued to low and middle-income countries, with over 80% of the returns, as illustrated in the pie chart on the right, would benefit upper middle and high-income countries, or very countries that are in the best position to make this global investment. The Organization for Economic Cooperation and Development, or OECD, comprised largely high-income countries, put out a report that shows how AMR containment measures could be cost-effective. AMR-related complications across 33 OECD and EU countries would cost over $3.5 billion in 2015 and 2050, much of them longer hospital stays. In OECD countries, a comprehensive intervention package that addresses AMR both in hospitals and clinics to improve hygiene and stewardship, and also in communities to delay prescriptions, mass media campaigns, and rapid diagnostic tests would come to just $2 per capita a year. Such an investment would avert 47,000 deaths a year in OECD countries, and the public health package could pay for itself in under a year and save $4.8 billion a year in OECD countries. We must keep this in mind when the drug industry comes calling for billions of dollars for boosting last mile investments and reimbursements for outbound bodies. These public investments will have to be weighed against the alternative interventions to tackle AMR that are highly cost effective and that can save lives. What could we do using these billions of dollars to finance a service package for low and middle-income countries modeled after the OECD proposal? This should also motivate even more the need to develop more efficient, sustainable, end-to-end approaches that bring low-cost antimicrobials to market. Thank you for the opportunity to share these reflections with you on the occasion of your third National Forum on AMR.
Thank you very much, Professor So. It doesn't mean that what happens because of COVID-19 will be bad always. We can learn from the lessons of COVID-19 and use that for checking for the AMR. But you know what? Very unfortunate that we don't have much time even to receive one question for the audience because the hotel just informed us that the list will be treated immediately. Otherwise, if behind 5 o'clock, we will be charged more. But I think that if you have any questions, you can give your questions to our secretariat so that they can write email to all these 4 speakers so that once they respond, they can get back to you. So this is something else that we can work out for. So we can see that from all 4 speakers, we give you different perspectives at a global level, and so enhance our horizons on how we effectively tackle for the AMR. So I would like to take this chance to thank you all 4 international speakers who are with us for the whole 1 and 15 minutes hours. So I would like to ask for all of you to give big hands to our 4 speakers. And I hope that we will have a chance to invite you more and give more time for all of you because we still have tons of questions, but unfortunately our time constraint. Thank you so much. And I would like to also close this session. Thank you for being with us for the last session. Thank you. เซสชั่นสุดท้ายนะครับเพราะฉะนั้นเรายังมีการประชุมที่จะเกิดขึ้นในวันพรุ่งนี้ที่น่าสนใจอีกนะครับวันนี้อาจจะมีประเด็นเรื่องของเวลาแต่พรุ่งนี้น่าจะไม่ใช่นะครับเพราะฉะนั้นหวังใจว่าพรุ่งนี้เราจะกลับมาที่นี่อีกครั้งหนึ่งตรงเวลาเพื่อที่จะเรียนรู้